Greetings, I'm Dr. Karl Nath, the Editor-in-Chief of Mayo Clinic Proceedings, and I am pleased to welcome you to the multimedia summary for the journal's November 2023 issue. There are 3 articles that have been selected as our editor's choice or highlights articles this month. Our editor's choice this month is an original article entitled Dietary Sodium Intake and Risk of Incident Type 2 Diabetes. It is authored by Dr. Zhuang Wang and colleagues from the School of Public Health and Tropical Medicine at Tulane University in New Orleans, Louisiana, the George Washington University Culinary Medicine Program in Washington, D.C., and the Harvard T.H. Chan School of Public Health, Boston, Massachusetts. Sodium provided by dietary sodium chloride or salt is vital because, among other functions, it maintains plasma volume, is involved in neural and muscle function, and enables transport processes in the kidney and gut. Salt is also historically significant in our taste and quest for it, and in our use, misuse, and control of it. Salt has influenced the course of humankind's history, a perspective so brilliantly described in Mark Kulansky's book, Salt, A World History. Finally, salt in inordinate amounts is a determinant of disease, for example, exacerbating hypertension and heart failure and increasing the risk for stroke. In the present issue of Mayo Clinic Proceedings, Wang et al. Provide evidence that increased salt intake associates with an increased risk of type 2 diabetes. Their study population involved more than 400,000 participants in the prospective UK Biobank study and who were followed for more than 11 years. During this period, more than 13,000 cases of type 2 diabetes occurred. As a way of reflecting dietary sodium intake, participants provided how often they added salt to their food, and this was graded as never or rarely, sometimes, usually, or always. In their prior work, Wang et al. Had shown that such measures of salt intake reflected chronic salt intake and salt taste preference. They also demonstrated that such indices correlated with cardiovascular diseases. Their present data revealed that the more frequently salt was added to food, the higher the risk of type 2 diabetes. Such an association was independent of conventional risk factors for type 2 diabetes, lifestyle behaviors, or socioeconomic considerations. The risk for type 2 diabetes also associated with spot urinary sodium concentration and estimated 24-hour sodium excretion. Finally, this association between dietary salt intake and the risk of type 2 diabetes was underpinned in part by adiposity and to a lesser extent by inflammation. The importance of this study by Wang et al. Is that it reveals that the simple, reflexive, seemingly innocuous act of reaching for the salt shaker and salting one's food increased the risk of type 2 diabetes, a disease with substantial morbidity and mortality. Small habits make a big difference, to quote best-selling author James Clear. In this case, not for the better. As James Clear's Atomic Habits makes abundantly clear, becoming who we wish to be involves inculcating desired habits and abandoning undesirable ones. An important implication of the study of Wang et al. Is that restraining the desire for salt and limiting the use of the salt shaker may lessen the risk of incident type 2 diabetes. Our first highlight article this month is an original article entitled Association of Lower Extremity Lymphedema and Non-Melanoma Skin Cancers. It is authored by May C. Anand, a research trainee from Meharry Medical College in Nashville, Tennessee, and colleagues from Mayo Clinic in Rochester, Minnesota. Chronic lymphedema, as occurring after mastectomy, is associated with an increased risk of an uncommon cancer, namely angiosarcoma. Drawing upon this observation, Anand et al. Questioned whether chronic lymphedema is generally associated with an increased risk of skin cancers. This retrospective cohort study involved patients with lymphedema afflicting the lower extremity and who were seen at Mayo Clinic from January 1st, 2000 to December 31st, 2020. The lymphedema and the non-lymphedema control groups each consisted of almost 4,500 patients. The median time to the development of the first skin cancer was approximately 4 years in the non-lymphedema group, but 2.7 years in the lymphedema group. Skin cancers, specifically squamous cell carcinoma, basal cell carcinoma, and cutaneous angiosarcoma, were all more common in the lymphedema group. Overall, the risk of skin cancer was increased almost twofold in the lymphedema group. A small subset of 24 patients had unilateral lymphedema, a subset that afforded the assessment of the number of skin cancers occurring in the lymphodematous lower extremity compared with the non-lymphodematous lower extremity in the same patient. The risk of cutaneous cancer was increased 2.65-fold in the lymphodematous lower extremity compared with the non-lymphodematous lower extremity, a propensity that was especially true for basal cell carcinoma. These findings by Anand et al. Demonstrating the increased occurrence of skin cancers in lymphodematous extremities thus indicate that a bidirectional relationship may exist between lymphedema and cancer. Treatment of cancer by surgery, chemotherapy, and/or radiation is known to disrupt lymphatic drainage and thereby predisposes the lymphedema. Chronic lymphedema per se, as shown by the present study, may be attended by an increased risk for skin cancer. The authors suggest that lymphedema predisposes to skin cancer through the synergistic effects of two pathogenetic changes that occur in lymphodematous tissue. The first is the regional immunosuppression that is known to occur because of compromised local immunity, and the second is the regional pro-inflammatory phenotype elicited by lymphedema. These important findings of Anand et al. Underscore the need for regular surveillance of lymphodematous tissue for the occurrence of skin cancer. Our second highlight article this month is a review article entitled Combined Pulmonary Fibrosis and Emphysema, a narrative review. It is authored by Dr. Masahiro Nemoto from the Graduate School of Medicine at Shiba University in Shiba, Japan, and colleagues from Ishihara, Japan, and Mayo Clinic in Rochester, Minnesota. Nemoto et al. Comprehensively review the syndrome of combined pulmonary fibrosis and emphysema, one that is insufficiently appreciated as a cause for chronic respiratory symptoms. The true incidence of this syndrome is accordingly unknown, an uncertainty also reflecting the current absence of a consensus definition of this syndrome. This review, based on a literature search from 1990 to August 15, 2022, begins with the historical backdrop to the recognition of this entity. The relative extent of emphysema and fibrosis varies in this syndrome, thereby giving rise to various types of abnormalities on pulmonary function tests. Indeed, spirometry may even be normal for the following reason. Emphysema promotes increased lung compliance and lung volumes on the one hand, whereas on the other, pulmonary fibrosis predisposes to decreased compliance and lung volumes. These divergent effects may offset one another, such that spirometry is relatively normal. Along with this, the chest radiograph may be relatively unchanged. Both lung processes, however, impair diffusion capacity, and thus an impairment in diffusion capacity that significantly outstrips changes in spirometry is a key diagnostic finding, as are characteristic changes on high-resolution chest-computed tomography. The authors point out that while combined pulmonary fibrosis and emphysema was once viewed as one of the manifestations of idiopathic pulmonary fibrosis, current concepts regard combined pulmonary fibrosis and emphysema as a possible consequence of diverse interstitial lung diseases, including connective tissue diseases, sarcoidosis, and hypersensitivity pneumonitis. The authors discuss the associated pathogenetic, including genetic and environmental factors that underlie this syndrome. A very helpful algorithm succinctly outlines evaluation and diagnosis of this syndrome. Its complications, including acute exacerbation, pulmonary infection, lung cancer, and pulmonary hypertension, are also reviewed. The authors broadly outline therapeutic strategies and emphasize in particular smoking cessation, pulmonary rehabilitation, the importance of prioritizing pharmacologic therapy for the underlying disease, and the consideration of antifibrotic or bronchodilator therapy. This outstanding and timely review concludes by underscoring the need for heightened awareness of this syndrome and for studies that examine the optimal management of combined pulmonary fibrosis and emphysema. You can access these highlights and editor's choice articles free of charge during the entire month of November. Please visit our Mayo Clinic Proceedings website at www.mayoclinicproceedings.org, where you'll find our online-only features and many news stories posted in the News from the Editor carousel on our website homepage. These are based on articles published in Mayo Clinic Proceedings. You will see other free content as well as articles published online in press. You will also find links to our social media by clicking the buttons at the bottom of the home page to follow us on Facebook, Twitter, and YouTube. On our YouTube channel, you'll find full-length author interviews called Insights and our MCP 60 seconds video article synopses. Our website also includes our Mayo Clinic Proceedings issue summary and Author Insights podcast recordings, which are available from our website on the home page as well as through iTunes. As always, we greatly thank you for your interest in and your support of Mayo Clinic Proceedings. We hope you found this presentation from the content of our website valuable. Our journal's mission is to promote the best interests of patients by advancing the knowledge and professionalism of the physician community. If you are interested in more information about us, our homepage is www.mayoclinicproceedings.org. There you'll find access to information for our social media content, such as additional videos on our YouTube channel or journal updates on Facebook. You can also follow us on Twitter. More information about healthcare at Mayo Clinic is available at www.mayoclinic.org. This video content is copyrighted by Mayo Foundation for Medical Education and Research.